It's 12:01, so let's get started. Good afternoon, everyone. Happy Friday here in Seattle. It's a sunny and warm one, so a great sign that spring is coming in Seattle before the rain starts again. Welcome to the Department of Medicine Grand Round Series. My name is Hao Tong, and I'm the UW Montlake Inpatient Chief Resident. Today, we have our lane speaker from the Division of Rheumatology. To help moderate our session today, we have also Dr. Christian Lute to introduce our speaker, as well as assist with the Q&A session at the end. Dr. Lute is an associate professor within the Division of Rheumatology, studying innate immunity in myopathies and other rheumatic diseases. Thank you, Dr. Lute, for being here today. I'll hand it off to you.
Thank you. And it's my privilege and honor to introduce Dr. Ingrid Lundberg, Professor of Medicine at the Division of Rheumatology, Karolinska Institutet, Stockholm, Sweden. Dr. Lundberg received her medical degree in 1977 at Karolinska Institutet, Stockholm, and became a rheumatologist in 1985, so having cared for patients with rheumatic diseases for almost 4 decades. In 1991, she defended her PhD thesis on anti-RNP antibodies, followed by a postdoc at the Mayo Clinic in a neuromuscular lab. She then returned to Karolinska after her postdoc and have since supervised more than 40 graduate students and postdocs in rheumatology, training the next generation of researchers and clinicians, which was also recognized by the American College of Rheumatology, resulting in this prestigious Excellence in Investigative Mentoring Award. Her research is focused on rheumatic muscle inflammation, myositis, and involves both clinical and experimental research using large patient cohorts. She is world-renowned with more than 300 publications in the field of muscle biology and is a frequent speaker at international meetings. Dr. Lundberg has, over the years, received several prestigious awards, including the ACR Master Award, a medal from Karl University in Prague, Van Bremen Medal from the Dutch Society of Rheumatology, the Big Silver Medal from Karolinska Institute, the Major Wyatt Prize in Rheumatology, and of course, later tonight, she will receive the Lane Lecture Award here at UW. So in all, we are very grateful to have you here with us, Dr. Lundberg, and are much looking forward to your talk.
Thank you so much, Christian. I just now need to check that you can hear me. Okay. Yeah, good.
All good.
Thank you for your kind introduction, and thank you for inviting me. It's really an honor to be here, and I really appreciate to be in your excellent environment, and we have had wonderful talks already this morning, so I'm looking forward to the afternoon as well. So these are my disclosures, and today I want to discuss with you a new way of subgrouping patients with myositis and to suggest that this may improve our understanding of this disease. So I will do this by presenting some cases representing, we say, the new spectrum of myositis. And in addition, I want to take this opportunity to discuss part of the management, which is the exercise, importance of exercise in these patients. So just a brief introduction. Myositis, as you know, is a rare disease. We have an incidence of approximately 11 per 1 million person years and a prevalence of approximately 14 per 100,000. It's slightly more common in women and men. And the peak years of incidence for both men and women is between 50 and 79 years. But of course, this disease could also have an onset in children. Typically, inflammatory myopathies, or myositis, as I will call it, is characterized by slowly progressive weakness, and in particular in legs and arms muscles, and low muscle endurance. So patients are easily fatigued in their muscle. And in typical cases, you also find infiltrates of inflammatory cells in muscle tissue, as you see here. But myositis is not only a muscle disease, and as you clinicians are aware of, patients may frequently have skin rash, they may have interstitial lung disease, they may have arthritis, which is more recognized recently. They may even have involvement of the heart. But for many years, myositis has been subgrouped into dermatomyositis, polymyositis, inclusion body myositis, cancer-associated myositis, and juvenile dermatomyositis. And this subgrouping has been based on clinical and histopathological difference. And all here share the symptom of muscle weakness. And treatment of myositis is mainly based on high doses of glucocorticoids in combination with immunosuppressive drugs like methotrexate or azathioprine. But unfortunately, this treatment has limited effects, and many patients are left with poor physical function. So what we want to hypothesize now is that different subsets may benefit from different interventions, but also that we need to know more about the molecular pathophysiology in these diseases and its subsets to develop new and more individualized therapies. So we now see an evolving spectrum of myositis, and I will illustrate this spectrum with presenting some cases. And the first case is a man who at the age of 26 came to our early arthritis clinic because he had pain in his hands, and he had clear synovitis in his small joints of the hands. He was tested for the ACPA and rheumatoid factor antibodies, but they were negative, but he had anti-Jo1 antibodies detectable. He had no subjective muscle weakness, and when we tested his muscle strength with this manual muscle test, which I will use to describe the strength of the patients, that is, we test 8 muscle groups, and the maximum score is 80, and he had no problems with that. His muscle enzymes in serum, like the CK, were normal. But knowing that patients with anti-Jo1 antibodies may have a muscle inflammation, I performed a muscle biopsy, and much to my surprise, we found inflammatory infiltrates, both T cells and B cells, but also degenerating fibers in his muscles. And a closer look at his skin, he had mechanics hands. And further investigations were performed because he had the anti-Jo1 antibodies, knowing that could be related to lung disease. So we tested his pulmonary function and found some slight decrease of function and diffusion capacity. And on a CT scan of the lungs, he had these discrete but very clear ground glass changes, indicating that he had an alveolitis. So when we come to diagnosis of this young man, how should we think? He had no clinically relevant muscle weakness, but he had inflammation in the muscle tissue. He also had inflammation in the lungs and the joints and the skin, and he was positive for anti-Jo1 antibodies. I think most of you think of the diagnosis of the anti-synthetase syndrome for a case like this. Now, anti-synthetase syndrome was described quite a long time back by Dr. Laurie Love and her colleagues as characterized by the combination of different clinical manifestations, one or more of the myositis, interstitial lung disease, arthritis. These patients could often have fever, Raynaud's phenomenon, and mechanics hands, and one of the anti-synthetase autoantibodies, like the anti-Jo1. And there is a strong HLA-DR B103 association with this phenotype. Now, this man, he was treated due to his involvement of the lung with a combination of prednisolone, cyclophosphamide, which was followed by azathioprine, and he improved both in the clinical manifestations of arthritis, and the pulmonary function test improved. And after 2 years, he stopped all treatment, and he is still in remission without any treatment. So he did very well on this treatment. So the take-home message from this case is that myositis cases may present with arthritis. Clinical muscle weakness is not always present. I think it's also interesting that inflammation in muscle does not always correlate to the clinical degree of weakness. And lungs are frequently involved in patients with anti-synthetase syndrome. And by now there are 8 anti-synthetase autoantibodies that have been identified and can be tested by commercial assays. And they have somewhat varying phenotypes, such as the interstitial lung disease is more frequent in the anti-PL7 and anti-PL12 anti-synthetase syndrome, whereas in anti-G1 positive patients, you have more of the myositis. And some of the other anti-synthetase autoantibodies are quite rare. So this now takes us to a way to subgroup myositis based on the autoantibodies, where we have the anti-synthetase autoantibodies that I have just introduced. We have 5 autoantibodies associated with dermatomyositis. We have the anti-MD5 that's also associated with lung involvement, the anti-TIF1 and anti-NXP2 that are both seen in juvenile onset dermatomyositis, but in adults also in cancer-associated dermatomyositis. The anti-MI2 antibodies is associated with a classical dermatomyositis with skin and myositis, and the anti-SIA antibody with a severe form of dermatomyositis, skin rash. We have 2 autoantibodies that are associated with mainly muscle disease, the anti-HMGCR and anti-SRP, and 1 antibody that is associated with inclusion body myositis, the anti-CN1A. So coming back to the anti-G1 positive disease and how it can differ in presentation, I like to cite this study from our Spanish colleagues that here in this slide, they present how the patients presented when they came to the hospital. And as you can see, almost 20% presented with polyarthritis and 30% with interstitial lung disease, 20% with interstitial lung disease and myositis, and 26% with myositis. So these patients may appear in different clinical departments. But it's also interesting to see that by time, many patients develop more manifestations, both lung and muscle, despite treatment. So we have to follow these patients carefully. Now I will present another example of the new myositis spectrum. This is also a young man who came to the clinic with pains in his hands. He also had some discrete skin rash. And this is quite a long time back now, as you can see. We couldn't make any diagnosis at the first presentation, but during the fall that year, he developed problems with dyspnea and started to cough. And over the new year, he became very severely ill with the severe dyspnea. And he also, when he came back, had a more typical skin rash indicating dermatomyositis, both on his fingers and his eyelids. He had arthritis and he had some mild muscle weakness. With the skin rash, we suspected a dermatomyositis diagnosis, but he had normal muscle enzymes. We used a microcatar. He had 1, where the reference is 3.3. Of the autoantibodies we had available for testing at that time, he was positive for anti-Rho. We performed a muscle biopsy, but it was normal. This is a typical normal muscle biopsy, is a cross-sectional, no inflammation or other signs of aberrations in the fibers. His main symptom was from the lung. So we did HRCT, and now this patient has clearly more changes in his lung than the previous cases, both inflammation, but also these thickening subpleural opacities. And he worsened in his lung very rapidly. And you can see his vital capacity deteriorated and his diffusion capacity. And we were still uncertain about the diagnosis. And we suspected still dermatomyositis. So we continued the workup on the muscle. And in EMG, he had positive signs of inflammation in his spine muscles. We performed an MRI. And as you can see here on this the white areas indicate inflammation in the muscle. And guided by the MRI, we performed a new muscle biopsy that you can see down here. And we still didn't see any inflammatory infiltrates, but we saw another aberration in using immunohistochemistry, and that's the major histocompatibility complex class 1 expressed in the fibers. And this molecule, MHC class 1, is normally not expressed in muscle fibers, as you can see here from a healthy individual, where you have the brown staining in capillaries of fibroblasts. But you can see the difference with the patient where you have the MHC class 1 expression on the fiber membrane, but also diffusely in the cytoplasm, indicating there is some abnormalities here, although it's not specific. So this patient, he was diagnosed as having dermatomyositis with rapidly progressive interstitial lung disease. And it was a very dramatic development of his pulmonary function. And we treated him with all immunosuppressive agents we had available, but without success. So finally, he ended up in the intensive care with ECMO. And after 2 months, we managed to find lungs for lung transplantation. And this was now 17 years ago. And this man went back to work, and he is still on treatment for the transplantation with a low dose of prednisolone, azathioprine, and tacrolimus. And he has had no relapse thereafter, neither in his lung or from his dermatomyositis. And as I said, this was quite some years back, and then over time, new autoantibodies were detected, and we had the possibility to test his serum that was stored and taken before the transplantation, and we found that he was positive for anti-MDA5 autoantibodies. And then we have followed the patients over time, and we actually published this case. And what you can see, which is interesting, is this is the time of lung transplantation, and here is the pulmonary function, which improved with the transplantation, and the MDA5 autoantibodies that were positive before had dropped after transplantation and have been seronegative since. So what type of myositis is this? Well, now it's called clinically amyopathic dermatomyositis. And this subset of myositis is characterized by a skin rash, which is typical of dermatomyositis. If you take a skin biopsy, it's consistent with dermatomyositis, and these patients typically have no clinical or laboratory evidence of myositis, although this patient has slight changes in his muscle. And these patients have a high risk to develop the rapidly progressive interstitial lung disease, and in particular the subgroup with anti-MDA5 autoantibodies. What has also been described for this subgroup of myositis is that the skin rash, besides the classical manifestations with Gottrons and the heliotrope rash, these patients have very particular changes, and you should look into the palm of the hands, not only on the dorsal side, because here you can have these very strange changes, and sometimes also with ulceration. And this was an MDA5 positive patient before and after rituximab. So don't forget to look into the palms. So the take-home message from this case is that in myositis, the muscle weakness may be mild, a clinically amyopathic dermatomyositis, and a normal CK does not exclude dermatomyositis. A normal histopathology does not exclude dermatomyositis, although the MHC class 1 expression could be helpful and support the diagnosis. In our case, the MRI pattern was helpful to identify edema. And of course, now we have the antibody that will confirm the diagnosis. So in our spectrum, we have the anti-MDA5, which of the dermatomyositis autoantibodies is associated with the strongly associated with lung disease. So then this patient, he developed a very severe form of interstitial lung disease. So who with myositis is at risk to develop this severe lung disease? Well, I think we can learn from this multi-center large cohort with almost 500 cases where they had, where 67 of the patients actually died, and most of them were anti-MDA5 positive, and most of them died from interstitial lung disease. And you can see the risk factors here for the severe disease is age, above 60, positive anti-MDA5 autoantibodies, but also signs of inflammation with an elevated CRP and a low oxygen saturation. So in these patients, we should be aware of the high risk of developing a severe lung disease. Of the patients with anti-synthetase autoantibodies, again, they are not all the same. And in particular, patients with anti-PL7 and PL12 have a more frequent and more severe interstitial lung disease. They have less of myositis compared to the Jo1s. And importantly, they have a worse prognosis and worse survival, as you can see here in this graph, where the anti-Jo1 patients had a better survival than the anti-PL7, PL12 positive patients. So the rapidly progressive interstitial lung disease that can be seen both in anti-MDA5 positive or anti-synthetase positive these patients has a very poor prognosis and with a high rate of mortality. It's important to try to identify these cases early and start aggressive treatment and tight monitoring of the pulmonary function. ECMO may be a rescue until the patients improve, or to lung transplantation that may be successful. So now I will present a third case. This is a woman. She was very fit and previously healthy, non-smoker, without any family history of muscle or rheumatic disorder. And she presented with a slowly progressive muscle weakness, in particular of her pelvic muscle. She had no other organ manifestations. And we performed an EMG that showed a severe generalized myopathy. And on MRI, if you remember the previous case, we had inflammation. Now we used the T1, the MRI version, and there here the white areas are representing fibrosis and fat replacement. So already when she presented, she had some of her hamstrings muscles were replaced by fat. We performed a muscle biopsy from the thigh muscle, and very disappointing and very surprising. These were almost normal. She has slightly elevated muscle enzymes in serums, 14 compared to the reference, 3.5, and her sedimentation rate and CRP, they were normal. Of the autoantibodies we had available to test at that time, she was negative for all of them. So she was diagnosed as having polymyositis, and she was treated with prednisone and azathioprine, but without any improvement of her muscle function. And the patient also wanted to plan a pregnancy and wanted to stop all treatment. So as we didn't have any improvement, we stopped the treatment. And what happened was that she had slowly progressive weakness, and though she was very physically active. A year later, I performed a new biopsy, and now we saw some changes indicated here. As you can see, these fibers don't look normal, and they represent both regenerating and degenerating fibers, but still no inflammation in the tissue. And the patient had a progressive muscle weakness, and we were still uncertain about the diagnosis. And I had a second evaluation by the neurologist, including limb girdle muscle dystrophy and Pompe's disease, but the genetics and some investigations were negative. So we couldn't confirm another diagnosis. So then the patients moved to another city in Sweden, and she was followed in the neurology clinic with a suspicion of limb-girdle muscle dystrophy, despite negative for known mutations. Then some years later, we learned about a new myositis subgroup discovered by Dr. Lisa Christopher Stein and Dr. Annie Mammon at Hopkins and NIH. And that was a condition with a severe myopathy, and this was associated with antibodies towards the hydroxymethylglutaryl-CoA reductase, the HMG-CR. And we had the possibility to screen the whole myositis cohort, our sera, with the help of Dr. Mammon. And when we had the results back, I found that this patient was positive for anti-HMG-CR antibodies. And this was described to be highly associated with statin use, but as you understand, this patient had not been on statin. Anyway, when I had the results, I contacted the patient and her neurologist. And as she had already tried immunosuppressive therapies before without any success, she was started on high dose of intravenous immunoglobulin, as there were reports that this may help in this subgroup of myositis. And remarkably, her muscle function slowly improved after 13 years of worsening. So the immune-mediated necrotizing myopathy is characterized by pronounced proximal muscle weakness, and often with high serum levels of CK, much higher than we saw in our patient. And other organ involvement is rare, including the lung. And typical for these patients is that in the biopsy, you find signs of fiber necrosis and regeneration, but limited inflammation. And there are two autoantibodies, as I already mentioned, associated with this subgroup, the anti-SRP and the anti-HMG-CR. And the anti-HMG-CR often associated with statin use, but can also be seen in patients without statin treatment, even in kids. And then there is a third group of this immune-mediated necrotizing myopathy, and that's if they are seronegative, they could be associated with cancer. And these patients are often very difficult to treat. So they will come back to our subgroup, and we have the immune-mediated necrotizing myopathy. So the take-home message from this case is that in people with suspected but genetically unconfirmed muscle dystrophy, you should consider immune-mediated necrotizing myopathy and test for anti-HMG-CR antibodies, even in individuals without statin treatment, as treatment with immune therapy may be effective. So now to our subgroups, we have identified the anti-synthetase syndrome, the immune-mediated necrotizing myopathy, the clinically amyopathic dermatomyositis, and most of them come from previously diagnosed polymyositis. So this group has really shrunk, and now we have these new subgroups. But we should not forget that we also have 20 to 30% of the patients are seronegative, and we know quite little about them. So we need to identify more of this phenotype. Now I also want to further discuss another subgroup with the anti-TIF1 gamma antibody, because this is one of the most frequent in adult patients with dermatomyositis, but it's also one of the most frequent antibody in children with dermatomyositis. And in adults, there is an increased risk of cancer in patients with dermatomyositis and TIF1 gamma. And we have done some work on this group, and I just want to illustrate what this clinical association with the cancer. And we screened we had 400 patients in the register, in our register with myositis, and found that 53 of them had cancer, and we had follow-up samples, serum samples from 47 of them that we tested for TIF1 gamma antibodies. And we found that in our cohort, 36% of the patients with the cancer-associated myositis were positive for anti-TIF1 gamma. And it was very striking that all of them had dermatomyositis. What also others have shown is the typical association with cancer and dermatomyositis in the TIF1 gamma positive individuals, which are the dark bars here, is that the cancer diagnosis is very close to the dermatomyositis diagnosis. So this is the time of dermatomyositis diagnosis, and you can see most of the TIF1 gamma were diagnosed with their cancer at the same time, whereas patients may develop cancer much later, but then they are less often TIF1 gamma positive. And this was from our collaborators in Spain. You can see the similar coincidence of dermatomyositis and cancer in TIF1 gamma positive individuals. We also found that there seems to be a risk for a worse prognosis, higher mortality in the individuals with higher anti-TIF1 gamma antibody levels. So how about the specificity of anti-TIF1 gamma with dermatomyositis in cancer? And we address this by testing sera from patients with cancer and those that have some paraneoplastic rheumatic symptoms and healthy individuals. And as you can see, the anti-TIF1 gamma antibodies were rarely present in just a very few patients with primary cancer and those with the paraneoplastic symptoms. So there was actually no difference compared to healthy individuals. So it's a quite specific antibody for dermatomyositis and cancer risk. So there is an ongoing collaboration to develop recommendations for screening for cancer, and this hopefully will come out to be published soon. But the anti-TIF1 gamma positive individuals is a high risk for cancer and should be subject to careful cancer screening. But approximately only 50% of those that have dermatomyositis and anti-TIF1 gamma will develop cancer. And the mechanism for that protection is not clear, but there is a very nice paper that was published last year explaining that some patients with dermatomyositis and anti-TIF1 gamma that do not develop cancer have a much broader spectrum of autoantibodies, including this anti-CCR1, and suggesting that these are protecting. So they have a more broader immune response to the tumor that may protect the individuals from developing cancer. But we need to understand this more. So then in this forum, I really wanted to say something about the management and the role of physical exercise as treatment, as this is one of the topics we have worked on in our research group. So I started to work and be interested in myositis in the 1990s. And at that time, the treatment of myositis was based on immunosuppressive treatment and rest. And this was the background to the project we started together with my colleague Helene Alexandersson, who is a physiotherapist, who designed a very modest home exercise program. You can see the interventions here, and we could actually, after 12 weeks, measure an improvement in those that have in these patients after the very modest program in the number of repetitions as we measured here. This made us perform a randomized controlled trial with patients at that time diagnosed with polymyositis and dermatomyositis. And we had an exercise intervention based on bicycling, followed by endurance exercise in different muscle groups. And this was done 3 times per week for 12 weeks. And the control group, also with polydermatomyositis, they continued to have their stable level of physical exercise. And I think this was very convincing of the results of exercise, because The exercise group, they improved in how long they could bicycle, and they had improved fitness. So that means that patients with myositis can improve by exercise just as healthy individuals. But what was also striking was that in the intervention group, we had an improvement in disease activity using this international myositis assessment clinical studies group. We have the improvement criteria based on disease activity like muscle enzyme, HAQ, physician and patient overall disease activity score. So 6 of the 9 patients in the intervention group improved, but only 1 in the control group. And so I think this and the results also from other groups internationally have now presented data that physical exercise in all subgroups of myositis is safe. And we have now data also to introduce exercise in early disease as soon as the patients are able to do some kind of exercise. And we know now that exercise is effective, both on strength and fitness. And moreover, exercise in combination with immunosuppressive therapy may reduce inflammation and also actually fibrosis, and can increase capillary density. So it's important to combine pharmacological immunosuppressive therapy with exercise. But the optimal training still needs to be defined. So now to the conclusions. We have over the past decades faced an evolving spectrum of the myositis disorders. And the identification of myositis-specific autoantibodies has helped us to identify clinically more homogeneous phenotypes than we had before. And we should all remember that extramuscular involvement may predominate, such as the joints, skin, or even the lungs. And some patients have only the lung inflammation, but with the typical myositis autoantibodies. And the lung manifestations, they are really common and can be the major clinical or only manifestations. So the autoantibodies are helpful in making the diagnosis and support the diagnosis of myositis, but they can also help us to make the prognosis and guide us in treatment decisions. And I think we have now evidence from different expertise groups that pharmacological treatment should be combined with exercise, which I think is natural that you think of that if you lose your muscle, it will not come back if you don't use them. So the exercise has a role, but may also have a role on the immune system to reduce the inflammation. So we believe that the autoantibody-defined subgroups, that may be a way to achieve a better understanding of molecular pathophysiology to improve treatment, moving towards precision medicine. And we see now, and I think it's important that in clinical trials that are designed, that you define the subgroups in a more specific way than previously polydermatomyositis. But to improve our understanding of this very complex and severe disease, we need to collaborate internationally and interdisciplinary, because these patients are seen in not only rheumatology, but in neurology, internal medicine, dermatology. So we established some years back in a European EU-funded project. We established a web-based register, and that was together with Dr. Hector Chinoy in Manchester in the UK and Professor Jiří in Prague. And this register that was originally called Euromyositis because it started within this EU-funded project. We now have collaborations that is extended beyond Europe, As you can see here, we have centers in US, in Mexico, but also in Japan, China, Vietnam, and many centers in Europe. So we renamed the register last year to called MyoNet register. And now we have more than 30 centers that have joined our collaboration. And we have more than 6,000 patients included in this register. And we will have data coming out now on some of the data from this register on the outcome and how we can use autoantibodies to predict outcome. So we welcome you to join our collaboration. So far, we have had it possible to be free for the investigators to use. You need an ethical permit to join. And we have a steering group that accepts the application and also decides about and approves research projects that where we can send in applications for using the research. And what is important is that each center owns their own data and can use their own data to follow the patients, but for you, then you can apply it to the steering committee, and each center has to approve if they want to join collaborations. And you can find more about this register on our website. So with this, I want to thank you all for listening. I want to acknowledge our multidisciplinary myositis team at Karolinska, but also our collaborators at Karolinska, in the lung clinic, in our research lab, and also collaborators in many other centers, like in Leuven, Dr. Loris and de Lange, in Amsterdam, Marianne de Visser, in Adelaide, Australia, Dr. Lima. Here in the US, we have a long-standing collaboration with Dr. Nagaraju and the MyoNet collaboration. And in particular, I would like to acknowledge my long-standing collaborator, Associate Professor Helena Alexander, a physiotherapist. And I also have a close collaboration with the epidemiologist, Associate Professor Marie Holmqvist. And we have this really multidisciplinary research group with clinicians, basic scientists, physiotherapists, occupational therapists, immunologists. So I'll stop there and ready to take questions. Thank you so much.
Wonderful. Thank you so much, Dr. Lundberg. And we have a couple of questions. And for those of you who are here, please do submit your questions through the chat function, and we'll get to those questions in a little bit. Just to start off, maybe I'll ask a question because I found it very fascinating with all of these cases you presented, and of course all of these different antibodies, and there are so many questions on what they're doing, if they're pathogenic and so forth. But I just wanted to contemplate on the first case you presented on this young man who had the anti-Jo1 antibody. I think in your second case, you demonstrated that the MDA5 antibody disappeared. But what happened in the first case? Do you know if he also got rid of his anti-Jo1 antibody, or if that remained while he was still in remission?
Yeah, he came back, I think it was last year, because I see the patient a couple of years after, and then they can call if they have any problems. And then he had some more pain. I think he also had some cough. So I saw him again, and I was a bit concerned. And that was also during the COVID time. But he came back. He didn't really have any clinical or other signs of myositis or lung disease. So I checked his pulmonary function, but he still had the autoantibodies. So in that case, they did not disappear. And of course, you wonder if there is a high, the risk for him to develop disease again, we don't know, but they did not disappear.
Excellent. I'll move over to some of the chat questions, and then we may come back to other questions or meet up later this afternoon, of course. On that topic, with autoantibodies and antigens, there's a question on, does anti-MDA5 antibodies suggest increased expression of MDA5 in the target tissue? And if so, does that suggest that a viral infection might be involved?
Oh, that's an excellent question. And unfortunately, we cannot answer that. That's one of the questions we are planning to try to answer by testing the investigating lungs, but it's difficult to find lung tissue. So if someone here is listening and has access to lung tissue from MDA5 positive patients, we will be very happy to collaborate.
In regular muscle tissue, I suppose, where you see typical dermatomyositis or anything like that, do you there see upregulation of the typical antigens that are targeted by the autoantibodies?
I cannot answer that because I must try to think. We haven't really looked for that, and I'm not sure if anyone else has done that for MDA5. No, I cannot answer that. I don't think we know. Well, we know from the sorry, now I'm thinking the group at Hopkins, they have some years back shown that there is a higher expression of some of the antigens that are targeted by the myositis patients in different tissues. So, for instance, the histidine synthetase, the target of J1, has a higher expression in the epithelial cells of the lungs. They have also shown that in muscle tissue, when you have a regeneration or when you culture cells and before they are fully differentiated, they express several of the autoantigens, like the histidine synthetase, some of the dermatomyositis antigens, TIF1, but I don't remember if MD5 was one of them.
Well, that's excellent. Thank you. Thank you. Another question here is, how often does one see significant esophageal dysmobility or reflux with these groups? Do you think that could be a differential symptom in these different myositis groups?
So the dysphagia of which can be subclinical, but so it's very important that you actually investigate this, because if patients have problems or are not recognized, and they may develop aspiration pneumonia, they can even die from it. So, but there in the subgroup, which I haven't really talked about today, is the inclusion body myositis, which is very difficult to treat. Up to 65% of them have dysphagia. It can develop over time. Another group where it's highly prevalent is in patients with cancer. And so patients with dermatomyositis and dysphagia, you should think of looking for, in particular, for cancer. So it can help us. But in some patients with dermatomyositis, the dysphagia may resolve. And so they may respond to treatment, whereas in inclusion myositis, it doesn't really improve with any treatment, any pharmacological treatment. So for patients with dysphagia, we have a very good collaboration with speech therapists and ENT doctors, because there could be different explanations for the dysphagia. It could be muscle weakness, but it can also be a proliferation of some of the muscles, so they become thicker, and that could be but dysfunctional. So those patients could benefit from that you make an incision in the muscle, whereas other can benefit from instructions on how you can exercise your swallowing muscles from the speech therapist. So it's a very important part of the management to have this contact.
Two questions on cancer, and try to combine them here. They're asking about the association between myositis and cancer, and when is kind of cancer developing with regards to myositis diagnosis, if it's before or after or at the onset. And I think you shared some of that data. On that topic also, they're asking questions about whether it's more common in myositis than in other, like lupus or RA, that you develop cancer. And if so, should we screen these patients for cancer?
Yeah, so the cancer, we can see cancer both before and after the dermatomyositis diagnosis. A definition for cancer-associated myositis that is often used is that cancers that are detected within 3 years before or after the dermatomyositis diagnosis. And in this group, that is where you find the high frequency of the anti-TIF1 gamma positive individuals. But the cancer, we did a study from the epidemiology using the registers, and then we saw that the cancer types were different in the cancers that develop before versus the cancers that develop after the myositis diagnosis. So in the group before, that was the cancers like ovarian cancer, lung cancer, colon cancer, whereas in the cancer types that develop after the myositis diagnosis, there we have some more unusual cancers like nasopharyngeal cancer, mouth cancer, skin cancer, and hematopoietic cancers were both before and after. So there seems to be some differences in pattern between those before and after. And then there was another question related to this.
About screening. Do you recommend screening? Mm-hmm.
Oh, yes, and that will be very important when we come out with international recommendations. But as I can tell you now from seeing the manuscript, and that is based on consensus from many involved experts. So there is a recommendation to have a basic cancer screening on all patients with myositis. Some patients are considered at low risk, and those are the anti-synthetase syndrome, inclusion body myositis. And then we have a group with moderate risk, which is often dermatomyositis, the immune-mediated necrotizing, and the high risk, those, for instance, older age, anti-TIF1 gamma and XP2 positive. And so all patients should be screened at baseline with according to the national or the routines you have in your country, but also to include in those with moderate and high risk, also include HRCT of the neck, of the thorax, abdomen. And in those with the high risk, if everything is negative at the time of dermatomyositis diagnosis, they recommend that you repeat the basic screening with after 1 and 2 and 3 years. So there will be recommendations coming up, but in general, as soon as patients don't respond to treatment or they worsen or have a flare, in particular those with skin rash, think of an underlying malignancy.
Excellent. We have quite a few people interested in autoantibodies and their whereabouts. I'm going to try to combine a couple of questions here, but let's take them one at a time. And one question is really, when do we see antibodies and how long do they or can they develop? So the question is, since ILD can often precede the onset of characteristic muscle and skin manifestations in patients who are negative for autoantibodies, do you usually follow up and see whether they develop antibodies, or do you think that when they have clinical symptoms, there is no more development of antibodies?
Yes, we have done this. We have tried to address this question in some subgroups, like the TIF1 gamma, those with the cancer or dermatomyositis. We can say 90% of them had the antibodies at the first presentation. It's very rare that you develop the antibodies after diagnosis of dermatomyositis. We have done it for anti-Jo1. Again, very rarely you see the antibodies detectable after you have starting treatment. And another antibody that's I will talk about on Tuesday, a muscle-specific antibody, again, very rarely it develops after clinical manifestation and diagnosis. For those other more rare antibodies associated with lung disease, I'm not aware of any longitudinal study, but often the patients actually, they come to the lung department, they are diagnosed with often idiopathic fibrosis or idiopathic inflammatory interstitial lung disease. And then somebody may take and test the myositis or scleroderma antibodies and find that the patients are positive, and then they are referred to us. So I wouldn't, if we look at the lung, those that come with isolated lung involvement, the patterns may predict if there is an underlying rheumatic disease. And that is if you have the so-called NSIP, the more inflammatory pattern, there is a higher risk that there could be an underlying disease. And we highly recommend that you check for the patient's autoantibodies, the myositis-specific autoantibodies. We don't, as a routine, check the antibodies again, but we rarely see patients with idiopathic interstitial lung disease. I don't know if anybody can answer that question, if there is a risk of the patients with interstitial lung disease without any antibody at time of diagnosis, if they will later develop antibodies. I think that's a good project.
And just out of curiosity, has there been done any kind of pre-myositis work, just like in pre-RA and pre-lupus? Do we know how long they precede the antibodies, the precede diagnosis?
There are case reports that have shown that the antibodies may be detectable a couple of years before, and then the patient come back with more specific symptoms. We are actually trying to do this by retrieving sera from our biobank, and unfortunately this was really prevented by the COVID, because it's the same organization that were responsible for the recommendations during COVID. So we still have the samples, we have identified them, but we have to get them out of the freezers.
Excellent. And there was one final question, or maybe two. Do we know anything? In this presentation, you wonderfully presented that autoantibodies can be used for diagnosis or prognosis, but what do we know about them when it comes to pathogenesis? Are they pathogenic? Are they actually doing something?
The best work to answer this question has been published and presented from the group in Paris, and that they have focused on the anti-HMGCR and anti-SRP antibodies. And they have very nicely demonstrated that both the sera and IgG from patients with these antibodies prevent in vitro the differentiation of muscle fibers. They also can see that the fibers leak like LD from the fibers when you incubate the fibers with sera from these patients. And they also have convincingly shown that transfer of the antibodies to mice model develop muscle symptoms. So I think that is the best indication that at least some of the antibodies may be pathogenic. Concerning the other antibodies, I'm not aware of any such studies, but we are trying to do it, and we'll see if we can show that the antibodies are pathogenic. From the clinical perspective, you would suspect that, but we don't know.
A quick question. I think we have time for one last question here. And I don't know if you have heard of this, Dr. Lundberg, but has anyone asked whether the HLA expression in muscle correlates with the subset of patients with cancer? So do you see more or less of HLA expression related to cancer development?
I'm thinking. I am not the AMHC class 1 or HLA class 1. The cases where this is most widespread is in the inclusion body myositis and not related to cancer. Concerning the dermatomyositis subgroup, we are trying to look into the tissues now. So I'm not sure if that could be a predictor if there is an underlying cancer or not. So that's a very good question. I would like to look at that data.
Excellent. I think that will probably finish up the session.
Thank you. Thank you for all questions.
Yeah, and thank you, Dr. Lundberg, for joining us today. And it's really an honor for us to be able to host you at our Grand Round session. I hope you have a good rest of your day. And thank you, Dr. Lund, for moderating the Q&A. It sounds like there was just a lot of really rich discussion and questions that came about from your presentation, Dr. Lundberg.
Thank you so much.
All right. For everyone joining Grand Round today, thank you, and we'll see you in 2 weeks.